Hey everyone, welcome. First, I want to say that I'm sorry it took so long for me to prepare something like this, but I knew that when we were all beginning to come back from COVID, that we all had a lot on our minds and a lot of things going on. And I'm sure, like myself, you probably got invited to more webinars than you could stand. And and so I thought I'd give ourselves a little bit of a break. But at the same time, I wanted to create an opportunity to get in that last and final and eighth study module that we missed in April. Just to kind of try to create that opportunity for people who wanted to get the most bang for their buck. And by the way, just related to that subject matter is I have an extensive library here of all the study modules and even some that have not been shown, which is what we're going to see tonight, one that I've had in the archives for a long time. And feel free to contact me anytime, and I'm happy to hand you over the DVD. And if it doesn't show on your study club microsite, what study modules we've done so far, I can certainly try to put together a list and get that to you if you're ever interested. I hope that you're all thinking about rejoining coming up here in August, and we'll hopefully be able to have a meeting in September where everybody feels safe. Also, I want to take this opportunity to remind everyone that this Thursday, July 23rd, is the study club event we're having for Greg. I hope you all got the invitation. I'll be sending out another reminder here in the next day or two. It's going to be at 6 p.m. at HC Tavern and Kitchen in the Fishers District off of 116th Street. We've got music, we've got food, we've got open bar. There's no reason for you not to be there, okay? So I hope to see everybody, and it'll be good to get caught up. This is an outdoor venue, so there'll be lots of fresh air. And also, I need to remind everyone that they just changed their protocol for this facility today, and they let me know that they do want people to wear a mask as they enter the building, but then once you get to our meeting area, no masks are required. Okay. All right. So what I'm going to do is I'm going to run this study module, and I'm going to and hopefully this recording is going to work, and then you guys will be able to watch this. I'm going to go ahead and put it on speed 1.25. Normally, when I screen study modules, I usually watch them at double speed. But I think watching it at 1.25 gets it down to about 20 minutes, makes it pretty digestible, but it's still very easy to follow and very easy to understand. And of course, you've got pause buttons. So if it's all right with you, I'm going to go ahead and start the video at that speed, and we can maybe talk about it Thursday if some of you have watched this. Okay, so hang on while I switch over to that, and let me go ahead and get this started for you.
Hi, I'm Steve Ratcliffe, Executive VP of Specialist Education here at Spear Education. Welcome to another Spear Study Club learning module. You know, sometimes, in spite of our best laid plans, we don't get to finish cases. And the case that I want to share with you today is one of those cases. However, even though the restorative dentist didn't get to do the final restorations, the results are so nice, and I think there's so much to learn from this case that I don't think you'll miss not seeing the porcelain. The other thing I want to talk about briefly is I'm really excited about this particular case because it comes from one of our visiting faculty members, Mike Melkers. And he and his interdisciplinary team have just done a really nice job of documenting and working up the case. And for those of you who are watching this, I'd like to encourage you to think about submitting cases as well. One of my dreams for Spear Study Clubs is that all of our learning modules that include interdisciplinary cases will come from our clubs, from those restorative dentists and specialists who are working hard to go through our curriculum and learn how to do the very best for their patients. So this is one of those kinds of cases. This is Chris. You've probably had a chance to review the pre-treatment documentation, so I won't spend a lot of time on this. But Chris came into Mike's office with a chief complaint of my teeth are really sensitive, I can't eat ice cream, a couple of other things. He hadn't been to the dentist for 17 years. And in spite of that long-term absence, his dental health was really pretty good. He'd been doing some things at home to take care of himself. One of the things that brought Chris back to the dentist was that he had two daughters that were starting to have dental care, and he wanted to be a good example for them. So I'm not going to go through all of the pre-treatment diagnostics. You've got those in front of you, or you've had a chance to review them. So what I'd like you to do now is pause the DVD, and I'd like your group to come up with a diagnosis or a problem list. And I don't want you to spend a lot of time on this. I think 15 minutes is more than enough. So you can pause the DVD here, and when you've completed your diagnosis, restart, and we'll go from there. Okay, so this is what Mike's team came up with, and I'll just go through some of the diagnostic slides. You probably noticed the wear on his front teeth. This is lips at rest and natural smile. And from the appearance, it doesn't look like Chris has lost a lot of tooth length. His lips at rest and natural smile show central incisors and laterals that have an appropriate length and an appropriate amount of display. There is, however, 100% overbite. And you notice that the wear not only is on the incisal edges of the maxillary anterior teeth, but also on the facials of the lower anterior teeth. He's got 100% overbite. If we look at the gingival levels of the four maxillary incisors relative to the posterior teeth, you can see that they're lower. They're also lower than the canines. So Chris has had wear with compensatory eruption. If you look at the occlusal shots, and you've had a chance to review the models as well, you'll notice that the wear in Chris's mouth is mostly on the anterior teeth, on the palatals of the maxillary anterior teeth, on the incisals of the maxillary anterior teeth, and then heavy wear on the facials of the lower anterior teeth. He has some wear on the buccal surfaces of the premolars, lower buccal, and the lingual inclines of the upper buccal cusps. He's in a class 2 relationship on the right side, a class 1 relationship on the left. And Chris also has a restricted pathway. The wear pattern that he demonstrates is classic of restricted pathways of movement, where you have that particular kind of wear on the front teeth. He also probably has steep eminentia, so that when his casts are mounted on the articulator, you're probably going to want to do a protrusive record so that you can mimic the angle of the eminence. One of the ways that you can tell that just by looking at the models is that there's heavier wear on the facial surfaces of the premolars than there is on the molars. When there's a steep eminence and the condyles translate, the back teeth fly apart more quickly in lateral excursions. As you move further forward in the mouth, in a lateral excursion, the premolars actually move in a slightly superior direction. And for instance, in the right lateral, the premolars are going to actually elevate just a little bit as they go out and do excursions. So if the patient is engaged in some sort of parafunctional movements, you'll likely see more wear on the facials of lower premolars than you will on the molars. And finally, because he's had supereruption of the lower anteriors and supereruption of the maxillary anteriors, it's resulted in a two-step occlusion, meaning that the lower anteriors are much higher than the lower posterior teeth. And he's into dentin on all of his anterior teeth, both upper and lower. And of course, here's Chris's panorex. He's had his third molars out. So now, I'm going to give you some questions to discuss in your group before we go further. As you look at this case, what's the biggest challenge? What's the challenge for you as the specialist? What's the challenge for you as the restorative dentist? Secondly, has Chris lost vertical dimension? Is that part of the discussion in this case? And finally, what are your thoughts on how he got this way? How did he end up with so much wear just on his front teeth and very little on his back teeth? So go ahead and pause the DVD, take 15 or 20 minutes and go through these questions. And when you're ready, you can begin again. Welcome back. So the challenges that Mike faced, obviously, are the severe wear. This guy's got a lot of heavy wear in the front of his mouth. Now, before we start thinking about how we're going to define all of this and what we're going to do, at SPEAR, we teach a very linear diagnosis and treatment planning protocol. And we always start with aesthetics. We always start with where should the front teeth be? How should they be oriented to the lips and the face and to the horizon? So if we were to draw in ideal in Chris's mouth, we'd lengthen the two front teeth a little bit, but we'd lengthen them cervically. We don't need to add much length to his maxillary incisors. They're not bad where they are. Maybe just enough to clean up the incisal edges a little bit. His laterals, probably we'd change the rotations, and his canines, we'd move just slightly. So if I'm going to create an ideal anterior tooth arrangement, this is what I might draw for Chris. Part of aesthetics is also looking at the inclination of the incisors, both the upper and lower. And the way that we do that is either in a photograph with a buccal occluded view or buccal view with the teeth slightly apart, or taking photographs of the models, is we draw a line through the maxillary central incisor and connect that with the occlusal plane. If that angle is obtuse, those maxillary teeth are probably reclined. If you had a very acute angle, they'd be proclined. And in Chris's case, obviously, they're reclined. We also do the same thing with the lower incisors. And in Chris's case, these teeth are also retroclined. Look at how obtuse that angle is. So we've got reclined lowers, and we've also got reclined uppers. So when you've got that sort of restricted interincisal relationship, anytime the teeth rub together, the wear is going to occur on the facial of the lowers and the palatal of the uppers. We also want to look at mandibular incisal plane, or excuse me, maxillary and mandibular incisal plane. And if we look at the incisal plane on the upper, it's not too bad. However, if you look at the lower, there's an exaggerated curve there, and the maxillary anterior teeth are quite a bit higher than the posterior teeth. And then the last thing that we want to look at are gingival levels. Now, we've already identified that Chris has lower gingival levels on his maxillary anterior teeth than the canines in back. And he's also got irregular levels of the mandibular anterior teeth. There again, that's just a result of over-eruption. The next thing, so we've looked at aesthetics, and we've kind of defined that he's got a very tight bite. He's got a tight interincisal relationship. The teeth are reclined, and there's a little bit of crowding, and then we added that the wear. The next thing that we want to look at is function. And we've already talked about Chris having this very restricted envelope. So without positive occlusal stops of the lower anteriors against the upper anteriors, teeth are going to continue to erupt. And as long as there's nothing holding them in place, those lower anteriors will erupt until they touch the palatal tissue. Now, part of what causes that constriction is ramus growth and also the actions of the lip and tongue. And we'll talk a little bit more about the ramus later. So when we're looking at function, and you look at the palatal surfaces of the maxillary anterior teeth, you'll notice on the slide there's a circle there. It almost looks like a little ledge. That's classic of a restricted envelope. That ledge hasn't worn in. That ledge is what's left. All of the cingulum has worn away. So we know that he is parafunctioning at some point. We also have a structure issue here. So as our system goes, aesthetics, function, structure, and biology. Structure, of course, is he's into the dentin on all of his anterior teeth except the lower canines. So when we think about structure, we think about what are we going to remove, what are we going to retain, what are we going to restore, or what are we going to replace or reposition. So when we think about Chris's structural issues, we probably have to replace some tooth structure. But obviously, that means that there's going to be an issue with where do we find room to do that. So we've identified some things as we go through aesthetics, function, structure. Biology is the fourth part, and there are really no biologic issues here with Chris, other than I think we identified in the preclinical notes that there appears to be a lesion on the apical of the distal root of number 19. So you'll probably have a discussion about endodontic treatment there. Other than that, though, what I'd like you to do is take about 30 minutes and create a treatment plan. When you're done, come on back. Welcome back.
Great plan.
I hope things got more clear as you were having your discussion. One of the questions I posed earlier is how did Chris get this way? And we will have a discussion about vertical dimension here in a minute, because I also asked if you thought Chris lost vertical. We know, though, that the wear occurs because teeth are rubbing against one another. And we also know that when we are eating or speaking, that our teeth don't touch with much force, unless it's an accident. So this is probably something that's going on either as a habit during the day or he is bruxing at night. If we think about the challenges facing us in restoring Chris's mouth, gingival levels really play into it. I've overlaid the diagram that I drew on the lips retracted shot. And you can see that to create this sort of ideal arrangement means that we need to think about altering the gingival levels. We also have to treat the deep bite. We need to give him room so that the anterior teeth can be restored. And we've got to think about the anterior wear. When I think about gingival levels, one of the things, as I'm going down, do I treat this or don't? What I think about is this an issue for the patient aesthetically? If it isn't, and if there is adequate display at rest, and if the smile doesn't show gingival levels, we may choose to leave the gingival levels where they are. If it is an issue for the patient, then we can either crown lengthen or we can intrude the teeth. If we crown lengthen, what we've got to be aware of is the shape of the roots and the shape of the crown. Now, Chris has nicely shaped central incisors, but he also has divergent roots on his centrals, and he's got narrow roots. So if we start to remove bone to create more tooth length and alter the gingival levels that way, there is a possibility that we could end up forming a black triangle. Depends on how far away we get the bone from the contact point. But that's something that we would want to be aware of. So what I want to know is, if I'm going to crown lengthen, and if I'm going to do it for aesthetic reasons, is it going to enhance the result, or does it pose a risk? Now, the other thing that I can do is think about intruding the teeth. And what I like about intrusion is that it's non-surgical. I can conserve bone. And in this particular instance, it may result in better aesthetics. Because as I slowly intrude the teeth and the bone goes with it, I don't have to worry about opening up space between the teeth. The other issue that we need to think about is Chris's deep bite. And if there is a deep bite, when is treatment indicated? Does every deep bite have to be treated? And the answer, of course, is no. We want to treat them if there's an aesthetic issue. We want to treat them, if, as in Chris's case, if wear is the issue, because aesthetics were never really his concern, but the wear and the sensitivity were. Or if the deep bite is getting in the way of function. Any of those three reasons are valid for pursuing treatment. So if we look at an orthodontic evaluation in Chris's case, there are a couple of things that we see. He's got class 2 tendencies. He's brachiocephalic. He's got a long ramus and a very square jaw. Now, if you have an orthodontist in the group, I'm sure the orthodontist can do a much better job of interpreting the Ceph than I can. So other than making those observations, I'm going to let that go. This is the tracing overlaid over the photograph. The orthodontist that was involved in this case is Steve Lemring. Mike and Steve have worked together closely for a number of years. And as we go through this, I think you'll see how talented the two of them really are. So if we're going to go ahead and treat this deep bite, what are the choices? Well, we can do it restoratively. We can do it with orthodontics, or we can do it with orthodontics or a surgical approach. If I think about occlusal vertical dimension, which really is what we're talking about here with when we're talking about the possibility of surgery or a restorative approach, I think we need to understand how it develops. And you know the definition of vertical dimension. It's the distance between two constant points when the teeth are in the maximum intercuspal position. Vertical dimension develops as a combination of two factors: ramus growth and tooth eruption. All of what I'm going to show you comes out of Prophet's work from the 26th Annual Moyer Symposium. It was a book that was published in 1999. So you see on the slide normal ramus, long ramus, and a short ramus. We see short ramus in what are called long face syndromes, where there may be an open bite and a very elliptically shaped face, very slender, narrow face. We see a long ramus in a patient like Chris, where they're more brachycephalic. They have a much more square appearance. And of course, normal ramus is someplace in between. In a normal ramus, teeth erupt and everything falls into equilibrium. With a longer ramus, it doesn't take much tooth eruption to alter the relationship of the anterior teeth. In a short ramus, it doesn't take much tooth eruption to alter the relationship of the posterior teeth. So in a short ramus, if the second molars erupt or have the opportunity to erupt quickly, it's easy to develop an open bite. In a long ramus, what happens is we can develop a deeper bite. So ramus growth and tooth eruption play into vertical dimension of occlusion. Chris, as we know, has a long ramus. He has a very square or flat mandibular angle, mandibular plane angle. And of course, he's developed the deep bite. Now, wear by itself is not evidence of lost vertical dimension. One of the questions I posed is, has Chris lost vertical dimension? We know that vertical can be altered, and we know that you can have loss of vertical dimension. And what we frequently see in lost vertical dimension are flaring of anterior teeth and loss of posterior stops. The other thing that can lead to lost vertical dimension, if the rate of wear exceeds the adaptive capacity of the dental alveolar complex. So, for instance, if somebody was working in a sandpaper factory and there was lots of alumina dust flying around and they weren't wearing a mask, and they happened to be grinding their teeth during the day, the exposure to that very abrasive dust could lead to tooth wear that exceeded the body's ability to create compensatory eruption. So it is possible that that individual could lose vertical dimension of occlusion. So in Chris's case, he's got anterior wear with very little posterior wear, meaning that the only teeth that have changed position are the front teeth. So without posterior wear, it's very unlikely that Chris has lost vertical dimension. He's probably very close to where he was when his permanent teeth first erupted. When we think about anterior wear, when does it require altering vertical dimension of occlusion? So if we wanted to think about a restorative case, when would that be? Well, we're going to open vertical if we need to lengthen both the anterior and posterior teeth, and if the resulting occlusion in aesthetics will be acceptable. Now, in Chris's case, we don't really need to lengthen posterior teeth. They're at a good level where they are. And we might need to slightly lengthen his anterior teeth, but that's more in a cervical direction. Now, because Chris has this restricted pathway, and because we know we need to restore his anterior teeth, and because we know we don't need to alter his vertical dimension, what do we have to change? Well, any restricted pathway requires increasing overjet. We've got to come up with a way to create room so that the restriction is alleviated, so that when he travels through excursive pathways, his teeth aren't going to rub together and wear. And when we want to restore his upper front teeth and his lower front teeth, we've got enough room to do that. So our options are, we can procline the upper anteriors, we can retract the lower anteriors, we can intrude either the upper or the lower anteriors, or we can do orthognathic surgery. So let's look at orthognathic surgery as an option. If, as I said, if you've got an orthodontist in the room, the orthodontist can give you much more insight into this than I can. But if we look at, and we've given you Steve Lemry's complete ortho analysis, all of the numbers. And if we look at the numbers, he's kind of a borderline surgery case, meaning that if we wanted to do surgery and use the surgical approach to help increase the overjet, it would mean that we would have to not only operate the upper jaw, but we'd have to operate the lower jaw. So in a borderline case, the orthodontist may choose to do this strictly with traditional braces. Or if the case were more severe, or if he were actually overclosed, the surgical approach might be indicated. But as I said, all of the analyses are borderline. And in a borderline case, the morbidity of double jaw surgery probably eliminates that as an option. So if we're going to eliminate orthognathic surgery, then we can either move upper teeth out, retract lower anteriors, or intrude uppers or lowers. Now, Chris's lower anteriors are already retracted, so there really is no room to move them back anymore. So we're going to eliminate that as an option. So that leaves us with proclining the maxillary anteriors, intruding both the upper incisors and the lower incisors. Now, we know that when we procline the maxillary anteriors that we're going to increase overjet as well. But because we don't like the relationship of the lower anterior teeth, we actually want to procline those teeth in addition to proclining the upper teeth. We still need to have room for restorative material. So how are we going to get that? When we're intruding teeth, one of the things that we know is that it's not a completely vertical movement. If you're intruding a maxillary anterior tooth, the intrusion follows the alveolus, and so you'll actually get some proclination by intruding. The same is true with the lower anterior tooth. As the tooth comes down, it also proclines. So the intrusion also helps us increase overjet. So here's our final diagnosis, and the treatment plan really is pretty straightforward. Classical orthodontic treatment, and restore 6 through 11, and then 23 through 26. The diagnosis is on the screen. You can read that. I'm sure it probably is pretty close to the diagnosis you all came up with. So here are Mike and Steve. I wanted to make sure that you see who this team is. So we've got our diagnosis. We've got our treatment plan. Now, for the orthodontist, the challenge is I've got to put brackets on these lower front teeth. How do I get room for that? And I also, as the orthodontist, I need to know where the gums need to go and where the edges of the teeth need to go. Now, years ago, orthodontists would line up the incisal edges and not pay attention to the gingival levels. Most orthodontists don't do that anymore. They know that we need to be very aware of where the gingival levels are, and that we worry about the edges later. However, there is a way to give the orthodontist more information. And so what Mike did was, in his lab, he did a very quick wax up, and he reestablished where he wanted the incisal edges of the maxillary centrals, and he also added back the lost tooth structure on both the palatal surface of the maxillary anteriors and the facial surface of the lower anteriors. Now, certainly you could have a lab do this professionally. Mike happens to like doing this sort of stuff. And he's just taken just layered wax to bring back natural contour. Now, the orthodontist needs room for those brackets. And there are many ways that they can do that. They can do it with a removable appliance on the upper arch that allows them to start the orthodontic treatment. They can bond little metal brackets on the teeth that are called bite turbos. Or in this case, because they were going to use some composite to replace lost tooth structure, they decided to build the bite turbos into the composite. See, what Mike is doing here is he's giving Steve the final length and approximate contours of the teeth before he ever starts moving teeth at all. So that Steve is now going to be able to move fully contoured teeth into their proper position. Much easier than trying to guess at where the teeth might end up. So Mike does transfer matrices, and he actually bonds these composites directly in the mouth. He builds the bite turbos, adjusts the bite so that they're hitting evenly on both teeth, and that serves to open the bite so that Steve can place brackets and have enough room to begin the tooth movement. Steve uses an indirect bracketing technique, so he places the brackets on the models and then takes them to the mouth. This is mid-treatment. The entire course of orthodontic therapy took about 24 months, and this is the way the case was finished. So it's a beautiful result. You can see his profile is slightly improved. The question, this is the post-treatment Panorex. You can see they did the root canal in number 19. And the question about did the bite open or not, and can you tell a lot of difference when the bite opens? Here are the tracings, both pre-treatment and post-treatment, and you can see vertical dimension was altered very slightly, hardly measurable. So the reference that's at the bottom of this slide, Gross and his group wrote a paper saying that in order to notice significant changes in facial profile, you need to open the bite more than 6 millimeters. Opening vertical dimension 2 to 6 millimeters results in very little change in profile. So if changing profile was one of Chris's desires when he first started treatment, then it would have become a surgical case. We don't do that with a little bit of opening that occurred here. All right, so as you end up this learning module, would you have done this differently? Is there something that about the way that Mike and Steve did the case that you disagree with, or that you would choose to take a different approach on? I think those kinds of discussions in your group are the most important, because after all, how they did the case is less important than how you all would do the case. They got a great result. I know you can too, but you have to be comfortable with your process and the way you work together. And finally, I'd like you to end your meeting by going around your group and everybody talking about one thing that they can take back to their office tomorrow that they learned from participating in this discussion. So thanks for being with us. We'll see you next time.
So I hope you guys enjoyed that. I know it was kind of short and sweet and a pretty simple case, but I felt like it had a really nice, simple, elegant solution. These overbite cases sometimes are very vexing, particularly when there's severe tooth wear and it's hard to know what to do. I love how going through the spear tenets of aesthetics, function, structure, biology kind of lead you to the treatment's options. And that's one thing that I've really picked up from utilizing that technique. Some of the things I learned in the module, we've all seen those wear patterns that he was talking about on the lingual of the maxillary incisors, and I guess I had not really, in all honesty, ever thought of those as being specifically restrictive pathway wear patterns. Certainly used to seeing those restrictive pathway patterns on lower anteriors, but I hadn't thought about the cingulum wearing away and creating those ledges. I know we've all seen that very often. And then at the end there, the thing about opening vertical dimension, having to exceed 6 millimeters to affect somebody's profile. I mean, that's pretty pretty significant. Usually we're only opening people a couple of millimeters at most. So anyway, thanks for your attention. I hope to see all you guys Thursday. Looking forward to getting back together and having some camaraderie and enjoying the summer evening and getting caught up with everybody. Thank you, and have a great day.